Good morning, everybody. We know that portal vein thrombosis happens because of four major group of factors: reduced portal flow, altered coagulation, vascular endothelial injury, and a host of other factors like endotoxemia, oxidative stress, and HCC in patients with cirrhosis. The lifetime risk of portal vein thrombosis in general population, as per autopsy studies, is around 1%. In compensated cirrhosis, it varies from 0.6 to 16% in different studies. In decompensated cirrhosis and HCC, it is as high as 35%. In one of the longitudinal studies of patients with cirrhosis, over 10 years, it was around 28%. The cumulative incidence was 12.8%, 20%, and 38.7% at 1, 5, and 10 years in another study. When you see a patient with cirrhosis and portal vein thrombosis, the first thing that you have to do is to make a diagnosis of whether we are dealing with a malignant thrombus or a non-malignant thrombus, and if it is a non-malignant thrombus, whether it is acute or chronic. A typical malignant portal vein thrombus is hypoechoic, has internal vascularity, is expansile, and you can see the thrombus in proximity to a tumor. On MRI, this thrombus is T1 hypointense and usually T2 hyperintense with enhancing and hyperintense on diffusion weighted imaging. Then you have to differentiate whether it is acute or chronic, which is done with the combination of ultrasound, CT and MRI, where the features of acute thrombosis are: it is hypoechoic, there is non-opacification of the vein with enhancement of the wall, and you can find that this is T1 and T2 hyperintense. What does this do to the liver? It can have no impact on the liver. It can extend into the splanchnic venous system and cause congestion of the bowel. It can cause development of chronic portal vein thrombosis and the consequences of chronic portal vein thrombosis like portal hypertension, and in rare instances it can cause worsening of liver function or acute portal hypertension. The data is heterogeneous and conflicting, and that is why there is differences in the opinions as to how these disorders can be managed. On one hand, you have studies like Engelsby's study, which shows adverse outcomes of portal vein thrombosis on natural history of liver disease. On the other hand, you have studies by Dominic Walla and Maruyama, which show no impact of portal vein thrombosis on the natural history of cirrhosis. Majority of the patients are asymptomatic. However, a proportion of occlusive thrombosis may precipitate decompensation due to reduction of hepatic blood flow leading to ischemic liver injury. Due to the hepatic artery buffer, this tends to happen in patients with early cirrhosis rather than patients with advanced cirrhosis. And of course, the second consequence of symptoms is extension into the superior mesenteric vein, which may lead to bowel congestion and bowel ischemia. For the management, we need to know the classification, and this is the classification which is now adopted universally across all the societies based on time, recent and chronic. If it is presumed to be present for less than 6 months or present or persistent for more than 6 months, based on the percentage occlusion of the main portal vein, completely occlusive, partially occlusive if it is more than 50% but not complete, minimally occlusive if it is less than 50%, and fourth is cavernomatous transformation. And then based on response to treatment or interval change, progressive, stable or regressive. Once you have a patient with portal vein thrombosis, should you do a thrombophilia workup in these patients? So if it is a childhood onset EHVVO, the answer is no. For an adult onset portal vein thrombosis, the answer is yes in the absence of cirrhosis. For a patient with portal vein thrombosis and cirrhosis, probably yes, based on the data from the West. If you look at the new Baveno 7 recommendation, it says various combinations of different risk factors for thrombosis can be present so that identification of one risk factor does not deter from a complete workup. So every patient, if you are suspecting, you should do a complete thrombophilia profile, not just any one factor. Coming to the management, anticoagulation in patients with portal vein thrombosis, who requires anticoagulation? So patients who are symptomatic, patients who have got a progressive disease. In these patients, usually you would start with low molecular heparin and switch to vitamin K antagonists when possible. DOACs can be considered as primary option in selected cases in the absence of Aplar syndrome, although the data is limited, although it is emerging, and the anticoagulation should be given for at least 6 months in all these patients. Beyond 6 months, long-term anticoagulation is recommended in patients with permanent underlying thrombophilic disorder, but should be considered even in those patients where the underlying prothrombotic state is not identified. If anticoagulation is discontinued, and this is important, this is based on the NEGM paper, D-dimer less than 500 nanograms per ml 1 month after the discontinuation may be used to predict a low risk of recurrence. Can we start anticoagulation in the presence of high-risk varices, and can we do band ligation in patients on anticoagulation? So the beta blockers may be initiated when you find high-risk varices, and you may start anticoagulation for these patients. Even a band ligation can be done if beta blockers are contraindicated. The anticoagulation should not be delayed in a patient who has been diagnosed with acute portal vein thrombosis. The benefits are lost of anticoagulation if you wait till the eradication of varices. Is there data to demonstrate safety of band ligation on anticoagulant therapy? The answer is yes. This was the first paper in 2018 which has demonstrated, and subsequently 2 more papers, one in 2018 and one in 2020, which demonstrated that there is no increased risk of doing band ligation in patients who are on anticoagulants. How do we really manage patients who develop anticoagulation related bleeding? We all know for vitamin K antagonists, it's easy. You give vitamin K, and if there is acute bleeding, you can give FFP or 4-factor prothrombin complex concentrate. For heparin, you can use protamine. For dabigatran, you have idarosizumab, and for factor Xa inhibitors, you have andexanet alpha. What about interventions in patients with portal vein thrombosis? So there are percutaneous techniques of portal vein recanalization. There could be direct methods where you go transhepatic and you directly try to open up a thrombosed portal vein. It could be a transjugular or a transfemoral route as well, which you can employ in certain patients, although it may be technically more challenging. Transsplenic in patients where a transhepatic route or a transjugular route has not been successful. In rare cases, you can go transileocolic as well, because the excess may not be possible from other places. This is especially true if you have had a subacute thrombosis which is there, and in those patients it may be difficult to canalize if from the transhepatic route. And then there are indirect methods which are used in very acute portal vein thrombosis with Bauer ischemia. These include intraarterial infusion of thrombolytic agents in the superior mesenteric artery. What are the techniques of the mechanical recanalization procedures? The most effective mechanical methods are the balloon angioplasty, and in those patients who have got a prior angioplasty already done where a stent is already in place, you can do a thrombus aspiration or pulling of the thrombus by balloon, and now you have a new catheter which actually rotates and it literally destroys the thrombus, and then you can suction it out. In case not only the main portal vein but the branches are also occluded, then the tips becomes technically very difficult, but that is the preferred modality. It will be very difficult if the branches are occluded for you to just mechanically open the thrombus and keep it patent. because the thrombus has extended from the main portal vein into the branches, and there, even if you recanalize the portal vein or the main right and the left branches, the thrombus is more likely to recur unless you establish a high flow system through the main portal vein by doing a TIPS for these patients. So, cirrhosis with portal vein thrombosis, what is the role of TIPS? This was a study of 70 patients, non-tumoral, non-cavernous thrombi. Recanalization was complete in 57% of patients and partial in 30%. What were the predictors of recanalization? Extent. So, if it was not extending into the branches of the portal vein, then it was more likely to be complete. And absence of gastroesophageal varices, obviously indicating that it was acute thrombus rather than an acute and chronic thrombus. Encephalopathy at the end of 1 year was present in around 27% of patients, but survival at 1 month was 99% and 2-year survival rates were to the tune of 81% patients. What do our guidelines say about when should we really do these interventions? So, portal vein recanalization may be considered in acute symptomatic portal vein thrombosis with persistent symptoms despite adequate anticoagulation. Second situation, acute symptomatic portal vein thrombosis with persistent thrombus if the main portal vein is thrombosed despite adequate anticoagulation, but the primary and secondary branches of PV are patent even if there are mild symptoms. What do you mean by this? If you have a thrombus in the main portal vein, the right and the left branches are still open. In this patient, if the patient has even mild symptoms and anticoagulation has not improved this patient, then you should offer early recanalization because this is the best chance to recanalize and do a interventional procedure. This patient is likely to have a progressive thrombus with occlusion of both the right and the left branch of portal vein, in which case the recanalization may actually become more difficult. So, with mild symptoms also, if you have a thrombus restricted to the main branch of the main stem of the portal vein, you must consider a recanalization procedure. These procedures should be done at expert centers and not for the first time tried at a center which is not used to handling such cases. PVR TIPS is recommended in patients who are listed for liver transplantation with thrombosis of the portal vein trunk without recanalization on anticoagulation. However, in these patients who are transplant candidates, the portal vein stent should not reach the main portal vein, rather it should be in the right or the left branch of the portal vein, and it should not, because the surgery otherwise becomes very difficult if the stent extends into the main branch of the portal vein. Coming to the last part, portal vein thrombosis and acute and chronic liver failure. 3 associations: type A, where PVT is the acute hepatic insult for precipitating ACLF in a patient with chronic liver disease; type B, where ACLF develops in a patient with pre-existing portal vein thrombosis and chronic liver disease; and type C, where PVT develops after the development of ACLF as a consequence of the ACLF. So, where there is type A, the portal vein thrombosis is the precipitant, we must make all attempts at recanalization. So, it could include anticoagulation, and if anticoagulation has not worked, then thrombolysis, TIPS, and TIPS with angioplasty. For type B, anticoagulation should be done only if there is a thrombophilic state which is present and there is no contraindication to anticoagulation, and majority of the patient will actually be excluded because this is a group of patients who are more likely to be infected, and once patients with cirrhosis who develop infection and sepsis, they actually become hypocoagulant and not hypercoagulant. Type C, portal vein thrombosis develops after the onset of ACLF. Their prevention is more important, and we still do not know much about this group, and probably once it develops, you may decide to treat it like type A. To summarize, my dear friends, portal vein thrombosis is often associated with thrombophilic disorders. Most acceptable and clinically relevant classification of PVT is by Northup. Extensive thrombophilic workup is warranted, including NGS if indicated in non-cirrhotic. In cirrhotic, you may decide to tailor make. Anticoagulation should be started immediately, and radiological interventions should be reserved for those who have portal hypertension complications. These are safe and successful in expert hands, though not yet widely standardized. PVT ACLF needs to be classified and managed on a case-to-case basis. Thank you very much, and I'll be happy to answer any questions at the end of the session. I invite you all for the APASL STC on improving non-transplant outcomes in patients with advanced liver diseases at Bombay on 7th, 8th and the 9th February 2025. Thank you very much.